Hello, everybody. Thank you for logging in. Very exciting talk tonight. As always, if you're interested in learning more about the SIR-RFS webinars or to get more involved, you can go to our webpage at rfs.sirweb.org. Also, if you want to send, we're going to go ahead and do the talk, and if you have questions, by all means, submit them via the chat box. You'll see a tab that says Send Questions to the Staff, and we'll try to get to those at the end, time permitting. I'm going to give the mic now to Aftab. He was instrumental in setting this up, and he's going to introduce our speaker. So, Aftab, you're up.
Hey guys, thanks for joining us tonight. My name is Aftab. I'm one of the second year residents in San Antonio. Today we have the pleasure of having Dr. Ezequiel Silva with us to give us a talk on future payment models and interventional radiology. Dr. Silva is the Director of Interventional Radiology at South Texas Radiology Imaging Center in San Antonio, and is also an Adjunct Professor at the University of Texas Health Science Center here in San Antonio as well. He completed his radiology training at Baylor and his IR fellowship at Mass General Hospital. Dr. Ezequiel is incredibly accomplished and a leader in radiology economics. He serves as the chair of the reimbursement committee at the ACR and is also the vice chairman of economics at the ACR. He has served as the chairman of the economics committee and the coding and education subcommittees at the SIR, and is also involved in high-level leadership in the Texas Radiological Society, and is among the youngest members to become a fellow at the ACR. So without further ado, Dr. Ezequiel Silva.
Hey, Aftab, I really appreciate that introduction. Like I said, this is Ezequiel Silva. I'm a practicing interventional radiologist in San Antonio, and I also get to do some really exciting, very cool things in regards to payment and sort of economic challenges that affect sort of the broader house of radiology, but sort of being an interventional radiologist and having in the past chair of the economics committee, and certainly having an incredible number of friends in the SIR. Interventional radiology is something that it really is a passion of mine. And we're really at an interesting time right now where we're seeing I call it a very rapid shift, but it's actually kind of a rapid and at the same time kind of slow-moving shift in the way that we're paid for physician services in general. And I say that across all specialties, but particularly radiology and interventional radiology. So it's I'm pretty confident, and I think it's pretty likely that we're going to see some changes over the next few years, and we're going to talk about those over the next few minutes. So if you don't believe me, look at what CMS is doing, the Center for Medicare and Medicaid Services. So CMS when the Affordable Care Act, and that's Obamacare, was signed on March 10, 2010. Well, Obamacare created the Center for Medicare and Medicaid Innovation. And there's dozens and dozens of projects, there's dozens and dozens of grants that CMS is allocating to different providers, different physicians, different radiology groups to study innovative payment models. And we have a couple affecting radiology, certainly several that involve interventional radiology at some level. So the question is, how long is it going to take for those, quote, innovation models to become reality? How long is it going to take till we see new payment models affecting interventional radiology and radiology in general? And it's relevant to this audience, it's relevant to trainees, because you gentlemen, you ladies are 3, 4, 5 years from being out into practice, whether that's academic or private practice, and you're going to want to effectively evaluate practice opportunities. You're going to want to effectively advocate for the success of those practices, but also for your specialty in general. So the question how long it takes is not one to be taken lightly. It may take 5 years. It may take 10 years. It may never happen. But if history tells us anything, let's look at other payment systems within the Medicare program. So DRGs, and outside might recognize this picture. This is one of my hospitals here in San Antonio. Well, the way hospitals are paid for inpatient care, including interventional radiology, is DRGs. So when DRGs, or diagnosis-related groups, became reality, it took 14 months for the government to initiate that program. Let's look at what's called the OPPS, which is the outpatient system. This is how hospitals are paid for outpatient procedures, an outpatient biopsy, an outpatient arteriogram. That program went into effect with no prior testing. It was statutory. It literally almost came into place overnight. And the system I want to talk in more detail about shortly, which is called the Resource-Based Relative Value Scale, had no testing whatsoever. It came into effect, was initiated, and within 5 years it was the standard of practice. So let's imagine for a moment, as an audience, let's imagine for a moment that it's going to happen really fast. In fact, let's imagine for a moment that the change in how we're paid for interventional radiology services is going to happen by the end of this talk. By the end of our session, and they tell me I have you gentlemen and you ladies till 10 p.m. Eastern time. So we have about 52 minutes to figure this out. And the way I want to do this is I want to do this kind of like you might do this if, say, you were in business school and this were a business school project. The challenge is, one, we only have 50 minutes. Two, we can't really have the kind of bidirectional exchange that might be necessary to accomplish this. So I'm going to guide you through this discussion. I'm going to guide you through the evolution of a new payment model for interventional radiology. And along the way, we're going to encounter challenges. We're going to encounter questions. We're going to encounter points in time where we're going to have to collectively make a decision. And we're going to make that decision. And the point I want to make along the way to you is the following, is just how complex this exercise really is, or, depending on your perspective, how simple this exercise. And we're going to ask that question at the end, and we're going to make a decision on that together. So there's this saying that you hear in business or you hear during strategic discussions, and that's thinking outside the box. And I'm okay with the phrase, but I have to say, if someone approaches me and says, Dr. Silva, I'm thinking outside the box, what that tells me is that they're thinking inside the box, and I'm okay with that, because that tells me that they have a frame of reference with which they're working, and they're thinking, and they're consciously, purposefully leaving that frame of reference. So we're going to think inside the box, and we're going to think within the context of our current payment system, which means I have about 3 minutes to educate everyone on this call and everyone in the audience regarding how our new payment system is structured. Now, I happen to know that you've had talks during this lecture series from two very good friends of mine and two individuals who I respect tremendously, who are Jerry Niedzwiecki, who's the chair of the economics committee for the SIR, and Kathy Kroll, who's an absolute legend in the SIR, including being past president. And so they've talked to you a little bit about how, or at length about how the CPT process is structured. So let's go through this fairly quickly. So we have a CPT book, and in this CPT book is a number assigned to every procedure potentially performed by any physician. So there is a CPT code for an IVC filter. There's a CPT code for the components that make up an arteriogram, and they're all in this book. So you take the codes in this book and they're very granular. So for example, the difference between the image on the left and the one on the right is you have a single view chest x-ray on one side, and if you dictate or you report a 2-view chest x-ray, you actually get paid more money. The CPT code has a higher value. Likewise, if you're doing an aortogram on the left of the screen, you get reimbursed a certain amount. If, however, your report is quite detailed and you describe a mesenteric arteriogram, which is the SMA run that's on the right side of the screen, and you're very thorough and you describe potentially an intervention that you might do for a GI bleed or something of that sort, as we in interventional radiology incrementally increase up those CPT codes, we obtain a higher value. And that value, that payment, is determined by what's called the resource-based relative value scale. Remember, that's what I just said a few minutes ago, is the payment system which came into effect after Congress passed law with no prior testing, no CMMI in that whole first slide I showed, no testing internally or externally. It just came into effect. And it's a scale. And it's a scale which is based on relative value. So the lowest service on this scale is allergy testing, which pays about 0.01 RVUs. The highest end of the scale is a diaphragmatic hernia repair in a neonate, which pays about 108 RVUs. So you take that RVU, you multiply it by what's called a conversion factor, and that's your cash or payment amount. The system is almost literally that simple. So now, there's our box. So we're going to think, now that we understand the CPT and the RVU and the RUX and the RVS cycle, hold that thought, because that's our box. Now, before we engage in our exercise, we need to define what an APM is. So an APM is an alternative payment model You might hear the term accountable payment model, and there's a few types of APMs that we see. There's bundled payment models where instead of the current system where hospitals paid a certain amount and Dr. X has paid a certain amount and Dr. Y has paid a certain amount for the individual services, these are bundled payments that are centered around what I'm going to call episodes of care, which is the episode based in the third. There's also condition-based models where payers or Medicare will make a single payment to treat an entire condition. And that treatment of that condition may be based on a disease. It might be based on a specific acute or chronic disease condition, and that's going to very likely include payment for every physician, every hospital, every provider that's included in the care of that patient with that condition. So what are some conditions we might be able to consider? Well, there's a few, and every one of these has some interventional radiology involved. Is breast cancer, screening, diagnosis, treatment, biopsy, lung cancer, back pain, stroke. I mean, every one of these is key to what we do as radiologists and interventional radiologists every single day. So let's decide. So we're going to build a condition-based model because we've got a problem that we need to solve by the top of the hour. So since I get to lead this discussion, I will propose that we're going to create a stroke care bundle. We are collectively going to take the next few minutes and we're going to do it. Any of you out there with children will know this is Bob the Builder. Bob is saying, let's build it. So we need to listen to Bob, just like my 12-year-old tells me I need to listen to Bob. So let's do it. So what's our first challenge? So if we're going to build a condition-based episode of care, if we're going to say to physicians and say to hospitals and say to interventional radiologists and say to the payer community and the government that we're going to create a bundle for stroke, well, what's something that has to absolutely happen for that to occur? You have to have a trigger. You have to have some defined component which allows that stroke bundle to be initiated. And remember, let's get in our box. So in the CPT world, which is where we live now, if we do an aortogram, there's a CPT code, it's 36200. We get paid or coded a certain amount as interventional radiologists for doing that study. The hospitals have a whole different system, but nonetheless, for the same basic CPT code, they're paid. So one possibility for our trigger might be to use those same procedures and make our trigger procedure based. So we might say, okay, we're going to create an episode of care. It's going to be based on stroke. So what do most stroke patients receive? Most stroke patients that show up in the hospital have a CT because they have neurological symptoms, presumably. Many of those patients will have an MRI, a diffusion-weighted MRI to look for acute, hyperacute cellular injury, and a lot of them are going to have a CTA or an MRA. A lot of them are going to have, many of them are going to have a diagnosis. A diagnosis in the coding world, I didn't talk about this earlier, but let's get in our box for a minute. When we report procedures and CPT codes, we also report diagnosis codes. And there's a whole other book out there called the International Classification of Disease. And that book, because we're physicians and we're compulsive and we're thorough, includes every potential disease known to man. So just like we have a CPT book, which I showed you earlier, that has every procedure known to man, or at least American men, because that's a CPT, American Medical Association specific thing, it also has every diagnosis in the other book. And there's a few that we use in what's called ICD-9 today. So 434.91 would indicate an unspecified cerebral artery occlusion. 434.11 would be cerebral embolism with cerebral infarction. Some of you that are really acutely attuned to the economics challenges we're seeing might know that the next chapter, which comes into effect October 1st of next year, is called ICD-10. ICD-10 is much more granular, it's much more specific and much more descriptive. So ICD-10 actually has a code for cerebral artery occlusion due to embolization of the right MCA, and that's the ICD-10 code, or the left middle cerebral artery, or the right anterior cerebral artery, the left ACA, the right PCA. It's quite granular. So if within our CPT ICD-9 RUC space our box, we have this system. How are we going to translate that to our new system? Well, one possibility might be to say that the trigger for our new stroke bundle is going to be patients have to have had, or presumably will have had, a CT of the brain or an MR of the brain. And those are the two CPT codes there. We'd like to see an ICD-9 code for stroke, and we're going to use that combination as an objective test result. So we're going to say patients have these CPT codes, this MR code, and if they have this ICD-9 code for stroke, and there's a report that documents that that has occurred, i.e. proper medical record documentation, that is going to be our trigger to initiate this payment. Challenge number 2. Not all stroke patients are the same. We have to find a way in our new payment model to describe or assess severity of disease and risk adjustment. Because if you're a physician and you take care of a patient that has a subtle TIA or the hospital, that is very different than a patient that has a massive hemorrhagic stroke. There's embolic disease, there's occlusive disease, there's a whole spectrum we can see in stroke care. So how do we do severity in the box now? How do we do that in our CPT space? Well, you have a head CT, you have an MRI, you have an MR. These are studies we know exist. If you have one of these or both of these, or as you get more studies, presumably the more studies you have, the more severe your disease. That's just kind of an assumption, and CPT builds that out. So as you have more severity, you have more care, and you get more CPT codes, you get paid more. And frankly, that's kind of one of the criticisms we're trying to overcome in regards to the CPT fee-for-service payment system, is that we're not incentivized to do less, we're sort of at some level incentivized to do more. So we know in the CPT world that patients that have a head CT have the same CPT code. And that CPT code is paid the same whether it's the one on the left, which is kind of a normal CT, or the one on the right that's a massive MCI infarct. It's still the same CPT code despite how long it takes you to read one or the other. We also within the CPT space have sort of modifiers to accommodate complexity. So you can put a modifier 52 for a reduced service or 22 for an increased service. Remember, our bundle is probably going to have non-radiologists, non-interventionalists involved. So we have what are called E&M codes, or evaluation and management codes. These are the codes that many of us, hopefully on this call, or at least when we get into practice, are billing as interventional radiologists. But this is the bread and butter for a lot of physicians that aren't procedure-based. So physicians that see patients in the outpatient setting or the hospital setting have E&M codes, and they're graded by distributions of severity. So let's get back to our exercise at hand. So do we agree that there needs to be some manner to assess the complexity of stroke patients in our new stroke bundle? And I think the answer is yes. I think we have to. I think if we don't, then it's pretty unlikely that any physician is going to sign on to our plan, because they may or may not be willing to take on the risk that they're going to be the best in the community, and they're going to get all the super tough stroke patients, and they're going to find themselves with no ability to compensate for the higher complexity. So what are we going to do? We have to make a decision. Remember, we've got to do this by the top of the hour. So here's our decision. So we're going to do APM complexity. How we're going to do this might be based on the number of services performed. We may say that there's a certain threshold, and the more services these patients receive, the higher complexity we're going to pay. That's kind of what we do now. We may make it diagnosis-based. If there's more severe ICD-9, we're going to pay higher for that. We might use modifiers. We might use those DRGs that I described earlier. There's other risk stratifications models. HCC is not hepatocellular carcinoma. It's a hierarchical component system of complexity that's used by the government already for some DRG models. So we got to decide. So let's think. Let's ponder. These are all very good actions, very good possibilities. Let's do this. I propose that we're going to assess complexity using a similar system to the DRGs. So let's go left to right. So a level 1 DRG, or a DRG is MS-DRG 69. That's transient ischemia. That is by definition a stroke. That's going to be level 1 in our complexity model. Let's say level 2 is, in the gray, acute stroke where thrombolytics administered. And in the bottom, without comorbid condition. That's going to be level 2. The next level 3 is with a comorbid condition. So these patients have a stroke but also have some heart disease or also have some atrial fibrillation or some other irregularity that takes them to a comorbid condition, or they have a severe defect physically on exam. Or we could do level 4 and say major comorbid condition. Let's say patients had a massive stroke, has a hemorrhagic component to it, or perhaps an individual that's required a very aggressive level of therapy, i.e. an interventional radiologist or a neuroradiologist. So if everyone's okay with challenge 2 and how we just tackle that, this is my proposal. What's our third challenge? So we've already defined how we're going to trigger our new alternative payment model, our new condition-based episode of care. We've already tackled how we're going to assess complexity and risk stratification or risk severity. So now we have this very important decision to make, and this decision is hugely relevant to interventional radiologists. It's hugely relevant to us because of what we do. So what are we going to include in our bundle? Let's stay within the box for a moment. In the CPT world, you don't really have this problem because basically if you do something, you code it, you get paid for it. So that's what we have currently within the CPT model as it stands. DRG is how hospitals are paid. Hospitals have a coding system where they're going to be paid for essentially whatever they do. So here's our challenge. What are we going to include? Are we going to include a head CT in our bundle? Are we going to include an MRA? Are we going to include an MR? The answer is probably. Most patients of even minor severity are pretty likely going to include all of these things. So we're going to talk interventional in a moment, but stick to this thought. So if we're going to value a stroke bundle, and we're going to value that stroke bundle for a payment amount, how are we going to know how many head CTs to include, how many MRAs to value, how many MRs of the brain or with diffusion-weighted imaging to value? And then we're going to talk interventional in a minute because this is a huge part of this discussion. So let's try to make this an educated, data-driven decision. So let's stick to, and I'm an ACR, I do a lot for the ACR. I have to give the ACR credit for some of the data I'm about to show you, and I have to give sort of the ACR's resources credit for what I'm about to show you. So let's ask ourselves the question. So we've already decided that we're going to base severity on the DRG system based on medical severity. There is Medicare DRG 61. That is an acute stroke requiring thrombolytic therapy with a major complication or comorbidity. We have the challenge before us now to define what we're going to include in that DRG system. So what if I told you that we have the ability, or we've done this exercise where we've looked at DRG 61, we've looked at Medicare claims data submitted by hospitals regarding the studies which they perform. And we know from looking at that data that the average patient admitted to an American hospital where DRG 61 is reported has a total of 4.62 RVUs worth of CT reported during that admission. We know from my brief introduction a few minutes ago that the RVU scale is based on relativity, so I'm going to tell you right now that a CT of the brain has for a physician, because remember, those CTs that were done on that patient had a radiologist interpret them presumably at some point during the admission. That radiologist currently billed a CPT code and he or she was paid for that interpretation. But our challenge before us now is how are we going to pay that CT going forward? How are we going to value the imaging that's provided in the interpretation? Well, 4.62 RVUs, my friends, is 5.4 CTs per admission. So I will propose to you that we're going to pay 5.4 CTs per admission, and we're going to value our DRG payment based on that, or our bundle payment. Do the same thing for MRI. We know from the data that patients that are admitted with this DRG have 2.64 RVUs, which is almost 2. It's about 1.7 MRIs or MRAs per admission. Interventional radiology. We know from the data that patients that are admitted with this DRG have about 8.21 RVUs worth of, quote, interventional radiology performed during the admission. Now the challenge for us is, I don't know exactly on a code by code, we've looked at it, but it's in general terms, it's hard for us to know on a code by code basis what that interventional radiology entails. That might be a posterior circulation arteriogram like I'm showing you there, and I will tell you that a bilateral study of the vertebral arteries pays around 9 RVUs. So some of these patients are having cerebral arteriography. Presumably some of these patients are having interventions. Presumably some of these patients are having catheter-directed thrombolysis. Presumably some of these patients might, heaven forbid, have a clot and need an IVC filter placed. So we can look at this data more granular, but we only have about 25 more minutes to figure this out on this call. So let's speak in general terms. So I will tell you that if you take those numbers, those RVUs, and you multiply it by the conversion factor, which I showed you earlier in the presentation, that's about 436 Medicare dollars. If we do the same thing for the IR spend, it's about $326. We know from fee schedules that DRG 61 pays the hospital, not the physicians, but the hospital, about $16,000 to do what it does, to pay for ICU care, to pay for nurses, to pay for the lights, to pay for their staff, to pay for the phones. Okay, so that's the amount that the hospital's paid. So here's our challenge. Our challenge is evolving very quickly because we have to decide how physicians are going to be paid within our stroke bundle. The hospital is going to get paid an amount, but physicians have to be paid an amount. But see, we have an advantage on this call and in this webinar because we, entering this discussion, know secretly, how much radiology is paid in those DRGs, how much interventional is paid, or at least should be paid, or at least we know what the floor needs to be. So as we go into these discussions, who's going to be paid in our stroke bundle? Well, probably going to be some neurologist involved. They do an initial evaluation. Let's give them 1 inpatient visit per day. We know our radiology friends are going to be involved. We know our interventional radiologists, us, are going to be involved. There's probably going to be some ER docs involved. I think it's probably safe to say most stroke bundles are going to include these levels of services, these physicians. So let's plot it out. So the hospital, we already know, gets $16,000. Radiology gets $436. IR gets $328. Those E&M codes, here's their value. So the total amount is going to be around $17,481, potentially. That may be the amount that we propose for our new stroke bundle by the top of the hour. We have a problem, though, or hopefully I wish we never had this problem. We have a problem, and that's the following, is that complications occur. Things happen to patients. So we have to decide, because we're going to be asked this question, what are we going to do about complications? Are we going to just not pay for them at all? So say, here's our payment amount for our bundle. If you have a complication, you doctors and you hospitals, you need to just deal with it. Or are we going to pay for them individually in addition to our stroke bundle using what's called the fee-for-service system we currently use, some combination, or I might propose a warranty percentage. I might propose that we will pay a percent amount in addition to the payment amount I just described or I just proposed. So let's say, let's propose, let's do it. Let's make a warranty for that. And this is hugely relevant to interventional radiology because what do? Patient gets pneumonia and needs a chest tube. Who's doing that? It's us. Patient has a central line infection. Who's dealing with taking that perm cath out? Who's going up there and putting a new central line in? Or heaven forbid, that's our central line that got infected. Who's dealing with the DVT? Who's putting the filter in? Who's dealing with the abscess? Who's doing vertebroplasty if they fall? It's us. So we very much care how this discussion evolves, how this decision is made as interventional radiologists. So let's see, what are our amounts? So if we do 1%, it's $174, 2% is $348, and so on and so on. I propose that we make the warranty amount 2%. And I'm picking that kind of objectively, but that's sort of, if you look at the value-based payment systems that are out there, 2% seems to be a number that Medicare likes. So I'm going to say that we're going to add 343, 348 to our amount and take our amount up to 17,502. That is the base payment for what we do. That is the base for our bundle, and that takes care of our warranty. But we have another decision we need to make. We need to decide what we're going to do about these individuals, other physicians and consultants. So what if the patient needs neurosurgery involved? What if they need ventriculostomy tube placed? What if cardiology wants to get involved because of AFib? What if vascular surgery wants to get involved because maybe that patient needs a carotid endarterectomy? What if pulmonary? What if hematology? And so on and so on. I mean, you could keep going on the number of physicians that might want to get involved. How are we going to compensate those individuals? And how are we going to compensate these individuals? And I want to highlight neuro-IR because that's one of us. Neuro-interventional radiologists, I consider those to be one of us. Those are interventional physicians. They're active in the SIR. They're active in our practices. I have 3 or 4 of these in my practice. So with that said, it's pretty difficult, I think, for us to build out the value of what all these individuals do. It's going to be really hard for us to create a bundle that captures what those individuals do. So since we have to make a decision, since I get to guide that decision, I propose that we pay consultants and specialists separately by fee-for-service related mechanisms. So if the neurointerventionalist goes in there in the middle of the night and gets heroic and does a thrombolysis case, we're going to pay that person, we're going to pay him or her based on a fee-for-service system. If we're lucky and we structure it right, we as more general interventional radiologists might be able to get paid fee-for-service for that filter. We might be able to maintain fee-for-service payment for that abscess drainage catheter placement if we're finding ourselves dealing with a surgically based payment model down the road. Challenge 4. We have to do something about value, because the one thing about alternative payment models that everyone demands and everyone talks about are reducing payments, reducing costs. We have to do that. But no one is going to allow you to reduce costs by doing nothing or reducing costs by doing a bad job. It's just not going to happen. It's just not fair to patients. It's just not fair to the system. And frankly, we as physicians should be responsible for maintaining the value of what we do. And the fact that I have all of you on this call on an evening during a work week tells me that you care about your patients and you care about value. So let's decide what we're going to do about value. Let's go back in the box and let's talk about the physician quality reporting system. This is sort of the most established, most active system that currently pays physicians for value. So when you go into practice, when you join a large practice like mine, you are probably going to be reporting PQRS measures. And there's one, number 76. And if we as interventional radiologists, when we do a central line, if we practice competent sterile measures, if we do things like put on a mask or prep the field or use sterile instruments or use sterile gloves, stuff that we do every day, and we document that, we get thumbs up success from the PQRS system. And it's an interesting system because it's evolving fairly quickly. So what used to happen in 2011 was you would get a bonus. Well, now as we get to 2015, when we get down to 2016, we're seeing penalties. So that's the CPT world. Let's go and let's think about our APM, our alternative payment model world. What are we going to do about quality? How are we going to maintain? How are we going to prove? How are we going to demand? How are we going to establish quality within the alternative payment models I'm describing for you? And it's a complicated question. We could use some of the PQRS measures. We could say that any patient that's within our stroke bundle that needs a central line for their medications, that individual has to have sterile barriers provided for central lines. That might be one. We might say that patients that have a CT, and this is another measure, need to have some comment made regarding ischemia or the potential. There's a dozen possibilities. What are we going to do about measures to protect against underuse? what are we going to propose if patients that are going to be reported within the stroke model have no follow-up CT performed, or never have a diffusion-weighted MR performed, or perhaps we're within the window where an intervention could have benefited that patient, could have resulted in a better outcome, and it wasn't performed, or a patient was discharged too early. I mean, these are all questions that we're going to have to ask ourselves as we create our new bundle. So I would propose, because we have to make a decision, we have till the top of the hour to figure this out, I would propose that we're going to borrow several PQRS measures. We're going to demand that physicians reporting and hospitals reporting our new bundled episode of care are going to be mandated to prove their quality through quality measures, and if they don't, we're not going to pay them. If you are a hospital or you're a physician and you're putting a central line in and you're not putting on sterile gloves, I am not going to pay you. And I'm thinking everyone on this call is going to be okay with that. Who's going to be accountable? This is a big question that we need to answer. Because in the CPT world, if you do the aortogram and you report CPT 36200 or you're the hospital, you submit a claim. So you as the physician will submit a claim to Medicare. You'll give them your name. You'll give them what's called your National Provider Identification Number. You'll give them the code. You'll give them those diagnoses I talked about earlier. And then sometime later you'll get paid for that. You as a physician, by submitting this form, you are accountable for that service, one, being performed in the first place, but two, being performed appropriately as a complete service. You're going to put your PQRS measures we just talked about on this form, and those PQRS measures are going to be used to validate the quality. You as a physician are accountable. But as we evolve to our new stroke bundle, a single, and I'm going to say physician, quote unquote, a single entity is going to submit whatever reporting mechanism we choose, be it a code, let's call it a condition-based code. A single individual is going to submit that for all the services provided. That single individual has to be accountable for everything that took place in that patient's episode of care to submit that form. And if that person, that entity, fails, then that individual who's accountable won't be paid. And if that physician who's accountable is not paid, then none of us are getting paid. So it's a big issue. And that's really going to be coordination of care. I mean, let's be frank. I mean, there's not going to be a physician out there that's going to have the skill set to do everything necessary to take a stroke patient from start to finish. But some physicians are going to have to be accountable for coordinating the ER thrombolysis continuation, consulting with the cardiologist, consulting with the interventional radiologist, consulting with the neurointerventional radiologist. Someone has to be accountable for all of that. And the question we have to ask is, who's that going to be? I mean, can that be a physician? Can it be a physician group? Or must it at some level be a hospital? Or does it have to be a combination of both? Could we as interventional radiologists or diagnostic radiologists be so bold as to be the ones who are accountable for that? And we're kind of evolving now into sort of discussions about what is the larger role of radiology and interventional radiology in any healthcare enterprise. Because we're making the diagnosis. We already talked about that with the CT. We're coordinating care in many ways because you're picking up the phone after you look at that MRI and you're calling the ER doc and saying, hey, Dr. Jones, we've got a stroke here. You're within the window. You need to start the thrombolytics. You need to call the interventional neuroradiologist. I mean, these are things that need to be done now. And you're the interventional radiologist or the neurointerventional radiologist. You're actively driving that patient's care. And you're doing it in a quality manner. So this is a big question for the specialty, and it's a big question for us going forward, is what role are we going to play in this accountability? And it really remains to be seen. It's a fascinating discussion, and I wish I could fast forward, back to the future style 15 years and see how this evolves, because it's absolutely going to be fascinating to see that happen. And what limits of accountability? I mean, what are we going to do if I say, Dr. Jones, the interventional, or Dr. Smith, the interventional radiologist, you have been so bold as to take accountability for this patient. You have recommended that your colleague, Dr. Brown, is going to be the neurointerventional radiologist, you're going to be accountable for the quality of what that physician does. But then the patient says, oops, I'm going to leave your hospital, I'm going to go down the street to the other hospital, and I'm going to have a whole other doctor do my intervention, which is, by the way, completely appropriate for that patient to do. But what if that patient goes to the other hospital and that other hospital doesn't do as good a job as you've done or would have done? Should you be accountable for that sort of faux pas in care? Well, the answer is I don't know, but we're going to have to figure it out. We're going to have to figure it out by the top of the hour by the time we get this accountability episode-based care in place. Challenge number 6. You have all these doctors, you're accountable, you're taking this big payment, you're taking a big old $17,000, $20,000 plus payment for Medicare or whatever payer you're dealing with for just the bundle, and you've already told that payer, if we have complications, we have a warranty. You've also told that payer that if this patient needs some high-end neurointervention, then I'm going to bill you for that as well. Okay, you've gotten that payment. You are in the room. You're in the office. You're opening the envelope. There's your check. Okay, you have a very important decision to make, and that is the following: it's how are you going to allocate those payments across the multiple providers that took care of patients involved in that episode of care? Because I can tell you, those radiologists are going to want to get paid for all those MRs they read. Every one of them pays $75 today. All those E&Ms provided by the neurologist and the cardiologist, every time they see a patient in the hospital, they get paid about $200. I can assure you they're going to want something. They're not going to work for free. So this is a real question for us to ask and for us to answer. So we look, I mean, here's your base payments. I mean, we've already established these are the amounts. Are we going to pin this on the wall of the doctor's lounge? Are we going to say, okay, Mr. Hospital, you get this much, radiology, you get this much, IR, you get this much? I mean, this is kind of brings it all together. I am almost at the end of my talk. I'm not quite to the top of the hour, but I want to leave some time for questions, and I want to importantly leave some time for some ideas. Because if we promise, we committed, we're going to figure this out by the top of the hour, we have about 15 minutes to do that. So I'm going to wrap up in a minute, but I want to leave you with a couple of thoughts. You have some questions. So now that we've kind of built this model, and I will tell you, this is almost as simple as it gets to building a model like this. It becomes incredibly more complex when you start looking at variable cost inputs and fixed supplies, and you start looking at how some of these sort of cost-based measures are structured. But you can see already just how sort of either simple or complex that was, but how many questions came up? How many questions need to be answered? And there's some questions, let's just ask some questions about IR. Can we as interventional radiologists within these new payment models, can we survive independently? Can we function as individual interventional radiologists, or must we be affiliated with a larger, perhaps radiology practice, or perhaps a larger multi-specialty group? Okay. Are we subspecialized enough that what we do can survive being billed purely off RVUs or the fee-for-service fee schedule? Should we get into a silo and get the ACR and the SIR together and maybe bring in ASNR and bring in some of the other specialties and create an imaging or an IR bundle? Maybe go through that whole exercise we just did, but instead of being condition-based, let's create an imaging bundle or an IR bundle. Let's say every time a patient comes into the hospital, this is what we are willing to accept as payment to do everything. I will do all the IR in your hospital, no matter what, for this payment amount per patient. And here's an important question. If we really have this high level of condition-based care, if we really have these types of quality measures, this demand, these standards of excellence which are mandated for us, what's the role going to be for the general hospital? Is there really going to be a need for there to be in a certain geographic location 5 or 10 hospitals that treat stroke care that are certified to do everything I just described? Or should perhaps we have 5 or 6 hospitals that know how to start thrombolysis, that know how to treat a TIA, or at least initiate treatment, perhaps do the imaging, but before one of us jumps in as a neurointerventional and treats it, maybe that needs to be at a different place, a different defined center of excellence? Okay, I don't know the answer to that question, but if you in my audience today are going into practice in 3 or 4 years from now, and you're evaluating practice opportunities, or hopefully going into academics and really going to impact a specialty, these are questions that we're going to have to answer, or at least ask. What about non-interpretive activities? What are we going to do to get paid? There's a bunch of stuff I didn't even mention. Things that we might do every day. What are you going to get paid for going to tumor board or stroke board? What are you going to get paid for teaching? What are you going to get paid for going out into the community and doing educational preventive activities for your patients? Going to the local church or the local community and saying, I am the stroke neuro IR guru in the community. You, because you are 65, are at risk for a stroke. You can do the following things. How are we going to get paid for that? Because there's value there. And like I said, we have this hugely complex question that is the following: is all these complex cost measures, how's our system going to evolve? Because what is $17,000 or $18,000 today may be a completely different amount tomorrow, or 5 years from now, or 10 years from now. There has to be some body, a group of individuals charged with maintaining the schedule. I mean, these are all questions that we have to evaluate. So I'm going to close. I want to thank you, because these are the types of questions that I love seeing residents tackle. Because as much as I talked about thinking in the box, those of you on this webinar don't really have the same box to think about that I've had in my practice for the last 10 or 12 years, or that some of my more senior partners have been in for the last 30 years, or frankly, some of the leadership that I have the pleasure of working with every day. We're just kind of locked into the system. You as residents, you as fellows, you as trainees, you have a completely blank slate on which to draw and answer these questions, and to create these payment models, and to influence the research that goes into these new payment models. And if we do it right, and we do the exercise we just did in the last 45 minutes, but do it over about 45 months or 45 days, and we do it right, think about how incredibly exciting of a time this is. Think about the ability we have to impact our specialty, to impact our hospitals, and more important than anything in that whole discussion is to impact our patients. It's an incredibly exciting time. I'm so thankful that you guys were willing to sit through that for 45 minutes. And it looks like we probably have about 10 minutes to share ideas and answer questions. Thank you.
Hold on. Great talk, Dr. Silva. Thanks again for doing that. People are putting in some questions. I think that was a great overview and kind of a nice way to see kind of where we're going, especially a bunch of trainees, how we're going to get paid, and the questions we'll have to help answer. One question that came in: how do you see IR being involved in the prevention of disease? The educational activities you mentioned, are there other ways IR can bring value to the system via preventative services?
Yeah, it's a great question. So staying within sort of the bundled space, let's assume that we just created the sort of acute care bundle, acute stroke care. Well, there's a whole other spectrum of activity that occurs before that patient comes into the hospital. It's preventive care, right? So one possibility might be that we create a preventive stroke care bundle. We say that physicians that are engaged in activities such as smoking cessation, or in the case of interventional radiology, being actively engaged in screening for occlusive disease of the carotid arteries, or education regarding recognition of stroke. And if we are bold enough to get out there into that space of preventive care, then there's a very real possibility that we can somehow gain payment and make contributions in that sort of pre-acute care space. Now, take that same reasoning and ask yourself, let's go to the end. So the one thing I didn't really have a chance to finish in my acute care stroke bundle is what happens afterwards. So patients stable, patients recovered. We've done a great job treating their stroke. They're still alive and they're still functional, but more than likely they're going to have some deficits, just the nature of the disease. So how are we going to carry that patient through rehab and recovery? You know, IR probably won't have as much of a role, but it might, and we need to create a bundle at the end of our care. It needs to be sort of a rehab bundle, if you will. So, you know, how we structure that, I don't know, but I will say that I strongly believe that we as interventional radiologists need to be engaged in those discussions.
Thank you for that. Another question I had, so how, I mean, historically IRs haven't really had a good, strong evidence base. So how do we go about starting to have an evidence base to better make it easier to kind of prove our value?
Yeah, absolutely. And there's huge focus out there in proving outcomes, and how do you validate outcomes for what you do? So patient presents with a stroke. We go and we do incredibly amazing, thrombolysis, and we macerate, clot in the end. We do all these fancy things. So how do we assess the efficacy of what we just did? And that's critically important from a clinical perspective, because you really do want to have the ability to fall back on evidence-based medicine to guide your decisions. But if we're speaking from an economic payment space, we're seeing more and more focus on outcomes, and we're seeing more and more focus on quality measures, and they're not just things like did you, during your CT interpretation, did you comment on stroke, mass, or some other parameters within that. What we're actually seeing is more payment tied directly to outcomes, improving the quality of life, including increasing life expectancy, things of that sort. So it's really it's an interesting time, and it's something that's really going to be a challenge to us on the academic side, is proving the efficacy and value of what we do. Because right now, if there's a CPT code, everyone just assumes it's a good thing for you to do, and we're doing more and more of it. And we anecdotally have the evidence to show that it's beneficial, but the government and the payers, they want more, and they want us to be able to answer those questions, and it's a real challenge for us, and it's something that's going to evolve very quickly.
Okay. Dr. Silva, I had a question for you. So within these bundles that you discussed, how do you think clinical decision support software will play a role, and do you think that this will lead to kind of an algorithmic approach to patient care?
Yeah, it's a great question. So, and I appreciate it, Aftab. So, clinical decision support, I'm going to say it within the context of radiology, because that's what was just passed in some legislation called the SGR patch. So what we're seeing is within the next few years, we're going to see an evolution whereby a physician who wishes to order a brain MR, they will be mandated to consult with clinical decision support software. And that software is based on appropriateness criteria, and basically what it does is it guides decisions. So if the patient and you have to plug in the symptoms. If the patient's a 20-year-old with no focal neurological symptoms and he or she has a headache, the clinical decision support software will probably tell you that an MRI is not appropriate. But what the clinical decision support might tell you is if it's a 65-year-old with a right-sided motor deficit and confusion and a face droop, it's going to tell you, yeah, you probably want to get that MR. And the interesting thing about it is it's going to affect payment. Because if you go against the clinical decision support software, it is possible you will not get paid down the road for what you just did. So that's the point of ordering support. So what does that do for us as interventional radiologists? Well, what we may see is the evolution of not just clinical decision support for imaging, but we may see clinical decision support for larger algorithms of care. So the stroke patient that is on day 2 or day 3 of their admission, has this symptom or that symptom, does that patient really need a leg ultrasound? Does that patient really need an IVC filter? And it's not necessarily going to be us that are influencing those decisions. It's going to be the physicians on the wards, the consulting physicians. And those physicians are going to have to consult this sort of algorithm before they can call us and say place the filter. So it's hugely relevant to us, but it's not clear entirely whether we're the ones that are going to be engaged in those decisions. So it's interesting, we looked at this at the ACR level. So we were looking at some mammo bundles, and we looked at claims-based data. And we said patients that have screening mammography, women who have screening mammography, what are the different sort of algorithms of care that they undergo? Well, the most common was screening mammogram, diagnostic ultrasound, biopsy, etc. That was sort of the most common. We found that there were something in the order of, something 100 different potential algorithms of care, where a patient might have a screening mammogram and an MRI, or may have a screening mammogram, a diagnostic mammogram, no biopsy, but then surgery. And so it just shows you just how heterogeneous those types of clinical algorithms are. And it's data we're going to really have to get our hands around. And it's fascinating research for someone to do, because it's going to really impact kind of where we go. So looks like we have about a minute and a half. Any other questions? I want to be respectful of everyone's time.
Sure. There was one last question that came up. It's what do you think about using a payment scale based on a patient encounter model, regardless of the disease or intervention? They have this model now, and the federally qualified health centers and CMS likes this model for them.
So ask me the very first part of the question, where you were saying is it a patient encounter model?
Yes. What do you think about using a payment scale based on a patient encounter model, regardless of the disease or intervention?
Yeah, there are some larger payment models out there where a physician is paid a certain amount for seeing all of the patients within a certain population. It's called capitation. There are also payment models where they can assess risk stratification sort of at the CMS level. It's not necessarily disease specific, but most of the models are based on sort of comorbid conditions. So the challenge that we face if you're a physician and you engage in one of these sort of encounter-based models is how do you mediate risk? So if I open up my office and I do that in a very nice, quiet suburb, that's going to have a very different patient population, a very different risk stratification model than if I do the same thing in sort of a busy urban center or an inner city area where the preventive care is not as strong, where the income's not as high, where the education is not what it should be. And you have to find a way to incentivize physicians to enter both of those models, because both of those populations need care. Both of those populations deserve care. It's how do you enable physicians to do that without opening up a shop and going broke. And so that's another model, and that's another discussion that's going to be quite relevant to the future payment space. So it's a great question. Okay. Well, I'm going to let you close the call. Like I said, I want to thank you, and I want to thank everyone for participating, and really how much I appreciate this opportunity. Thank you.
All right. Thank you for giving us a talk, and thank you. Have a good night. I think that's